All right, there were other hands here. Yeah, Jerry.
I guess, is it Glenn?
Yes.
I guess I'd like to come back to Glenn's question just for a second. And Danielle, you need to weigh in on this too. In the old days, as I heard about it in family medicine, docs worked till till 10 o'clock. So why, if Glenn lets you know that his daughter needs to see somebody, I mean, you do this, I think, Ray, stay late and see. So, are you flagging some charts, Phil, that this person has to be seen by their provider when they come and when they call? Or can they see you, Danielle, and then you say, well, this is a big problem, you got to see Ray today or Phil.
The docs that I work with, whenever they can, will double book themselves, will do what they can to fit people in, but a lot of the time what people are faced with is that the docs have already double booked and triple booked themselves and are already scheduled out to be there till 10 o'clock that night seeing their patients. And
They're really there till 10 o'clock?
I definitely have a couple of docs in my clinic that are quite frequently there much later than.
Okay. So we don't go to those docs. There must still be an answer to that question, I think, because that's what you guys are trying to do, is to integrate care.
I think some of it is about also creating a team that I mean, when we're talking about integrated care, you have to create a team of trust instead of just having one person that you trust. You have to have a team that you trust. You have to have a clinic that you're comfortable with, that you can, I mean, I can only speak for even how I want my own health care provided, that I want to know that if my doc isn't available for whatever reason, that his partner is someone who is going to take care of me in a way that I'm accustomed to, that clinic provides care in a good way and in a way that I'm comfortable with. And I think that that's what we hope for our family members when we have specific concerns like that. I think that those are the cases that I would hope that the docs feel like they have a social worker or someone who, even if they can't be there, that could be there alongside the patient, alongside of the family, to add one more comfortable, familiar face who could maybe preemptively talk to whoever is going to see that patient and say, here are some things to keep in mind before you walk in that room.
See, that works fine for me. I don't expect to see my primary care giver when I call. I don't. I always ask. They always say, check. 3 weeks is as soon as we can get to it. And then I say, I need to see someone right away. And then I get someone within a day or two. That's what I expect. I'm okay with that. I go in, I've never seen a person before. I trust they're a member of the team. Doesn't work for the family.
I'm going to just throw out one more thing, that we don't have anyone sitting up here that's on the panel right now, but the other way that this integrated care we're trying to provide it is also to bring primary care into mental health settings. And I think that I think that there's at least some groups doing some of that here in community mental health, of making sure if you can't get into your primary care doc, but you can get in to see someone that you are comfortable with, what are the different ways that we can do this? And if you have a psychiatrist that you're comfortable with, or you have a social work clinic that you're comfortable with, and they have someone who can help, a nurse practitioner or someone, again, that's a familiar face, that's a comfortable place to be in the scope of whatever mental health you're dealing with. So I think that the idea is really that we're doing this in a couple different levels and in a couple different ways.